Welcome to my presentation on the clinical fallout of type 2 diabetes mellitus. In this presentation, I will briefly explain the technical aspects of what happens at the neurological and cellular level when one is diagnosed with type 2 diabetes. Along the way, I will weave in a real-life scenario of how it often plays out and the impact it has on the various body systems in many patients who have type 2 diabetes. The regulation of the endocrine system, including insulin response and blood glucose levels, is primarily controlled by the hypothalamus and the pituitary gland in the brain. The hypothalamus is the key brain site for central control of the autonomic nervous system. The hypothalamus is a crucial brain region involved in maintaining homeostasis, including regulating body temperature, hunger, thirst, heart rate, blood pressure, respirations, and glucose metabolism via the autonomic nervous system. It's a small part of the brain that regulates a lot of the body systems. It's located inferior to the thalamus and is part of the limbic system. In humans, it's about the size of an almond. Here in this anterior view of the brain, you can see the pituitary gland. The hypothalamus has neurons that can sense blood glucose levels and respond to fluctuations. The hypothalamus communicates with the pituitary gland via releasing and inhibiting hormones. These hormones control the pituitary gland's secretion of hormones that influence various endocrine glands. The pituitary gland releases several hormones that indirectly influence insulin and glucose metabolism. For instance, it releases adrenocorticotropic hormone, ACTH, which stimulates the adrenal glands to produce cortisol, a hormone that affects glucose metabolism and insulin sensitivity. The brainstem, part of the central nervous system, also plays a role in regulating the autonomic nervous system, which affects processes like heart rate, blood pressure, respiration, and digestion. This system interacts with the endocrine system to modulate blood glucose levels, especially during stress responses. Insulin production is primarily controlled by the pancreas, which has insulin-producing cells called beta cells located in the islets of Langerhans. The pancreas responds to blood glucose levels, but this response is influenced by the hypothalamus and the overall state of the body's metabolic needs. The hypothalamus senses changes in blood glucose levels, and through its control of the pituitary gland via the sympathetic nervous system, influences hormones that affect other endocrine glands and organs involved in glucose regulation. A common scenario that happens a lot more than we realize, especially in Hawaii due to our high rate of type 2 diabetes, is the following. An overweight, clinically obese person who has been diagnosed with diabetes notices that they're gaining weight, particularly in the lower half of their body, their abdomen, and oftentimes in their peripheral limbs, including their legs, feet, and sometimes their arms and hands. Sometimes they gain it everywhere, but they've always been fluffy, so this isn't anything new, right? They start justifying it by saying their metabolism is slowing down and they're getting older, etc. What often happens is that their type 2 diabetes mellitus, which is caused by insulin resistance, starts to affect their heart, lungs, and kidneys. High blood glucose levels can damage blood vessels and nerves, leading to cardiovascular complications and worsening kidney function. Additionally, diabetes often leads to hypertension, high blood pressure, which can further strain the heart and kidneys. Type 2 diabetes mellitus is a complex condition with multiple contributing factors. It primarily arises from a combination of genetic, environmental, and lifestyle factors. In type 2 diabetes, the body's cells become resistant to the effects of insulin, a hormone that helps cells absorb glucose from the bloodstream. As a result, glucose accumulates in the blood rather than being used for energy or stored. Initially, the pancreas compensates by producing more insulin, but over time it may struggle to keep up with the demand, leading to higher blood glucose levels. Family history, ethnicity, obesity, sedentary lifestyle, a diet high in sugar and fat intake, Nutrient imbalances like lack of protein and a lack of magnesium and fiber, which helps regulate blood glucose, along with age and endocrine disruptive conditions that can lead to hormone disruptions like PCOS, polycystic ovarian syndrome, or other hormonal imbalances, can all lead to type 2 diabetes mellitus. Hypertension or high blood pressure and dyslipidemia, abnormal lipid levels, such as high cholesterol or triglycerides, are also associated with an increase in type 2 diabetes. It's often a question of what came first, the chicken or the egg. There are other socioeconomic factors that impact risk for type 2 diabetes as well. Diabetes can cause damage to the heart muscle, leading to diabetic cardiomyopathy. This condition can weaken the heart's ability to pump blood effectively, which may contribute to CHF, congestive heart failure, and consequently conditions like pulmonary edema. Diabetes can also lead to kidney damage known as diabetic nephropathy, which impairs kidney function, contributes to fluid overload, and pulmonary edema. When the heart is compromised enough, the patient will enter congestive heart failure. The heart is unable to move all of the blood and wastes and CO2 that builds up in their blood and body, and it starts to affect the rest of their body. It starts accumulating in their limbs, trunk, torso, and lungs. In congestive heart failure, CHF, the heart's impaired pumping ability due to reduced stroke volume and ejection fraction leads to fluid accumulation, peripheral edema, and increased pressure, exacerbating renal function. The heart's inability to manage blood flow properly can cause or exacerbate hypertension, which is a risk factor for kidney damage. This can elevate blood pressure due to fluid volume overload, further stressing the kidneys, especially in the presence of type 2 diabetes, which damages blood vessels and impairs waste removal. Right-sided heart failure is usually responsible for peripheral edema. This is because the heart is unable to fill with enough blood, and the blood backs up into the veins. When this happens, patients' ankles, feet, legs, and abdomen will swell. Right-sided heart failure is usually caused by left-sided heart failure. CHF, particularly left-sided heart failure, results in pulmonary edema due to blood backup in pulmonary veins, causing fluid leakage into air spaces, the alveoli. Patients often present to the ER with dyspnea, mistaken for asthma, and are diagnosed through tests like the basic and comprehensive metabolic panels and urinalysis to assess kidney function and protein levels in urine. This condition may also lead to decreased estimated glomerular filtration rate, eGFR, and microalbuminuria, indicating compromised kidney function. But left-sided heart failure can also be caused simply by high blood pressure, and therein lies the problem with diabetes. It damages the small blood vessels, causing the walls to stiffen and function improperly. This leads to hypertension, along with a whole host of other chronic health problems. Diabetes can damage the small blood vessels in the kidneys, leading to chronic kidney disease, CKD. CKD disrupts waste filtration and fluid balance, worsening fluid retention and hypertension, which aggravates CHF. The kidneys also influence glucose homeostasis through gluconeogenesis, glucose filtration, reabsorption, and consumption. CKD can complicate diabetes management and exacerbate hypertension, leading to cardiomyopathy, which can also lead to pulmonary edema. The renin-angiotensin-aldosterone system, the RAS system, regulates blood pressure and fluid balance, and many antihypertensives target this system, including ACE inhibitors, angiotensin-converting enzyme inhibitors, ARBs, angiotensin receptor blockers, aka angiotensin II receptor agonists, and beta blockers. During hospitalization, patients may receive diuretics like furosemide and strict fluid restrictions to manage fluid overload, though these can cause blood glucose fluctuations, electrolyte imbalances, and hypotension. Long-term management often involves a low-sodium diet, careful monitoring of fluid intake, and potential rehabilitation. If their kidneys are failing, they may need to be started on hemodialysis. Many times patients don't understand why they are having their fluids restricted, especially because we've all grown accustomed to hearing how water is the best thing for us. Unfortunately, when one's heart, lungs, and kidneys are so compromised, Not following the fluid restrictions can eventually become a death sentence. The patient will literally feel like they're drowning and can't catch their breath because they can't expel enough of the CO2 that is building up in their body along with the fluids. Both renal failure and CHF can lead to electrolyte and acid-base imbalances. Diabetes can also affect electrolyte levels as hyperglycemia causes hyperosmolality and impaired renal function. Imbalances can cause severe symptoms, including cardiac arrhythmias, irregular heartbeat, and death. Diabetes and CHF both increase the risk of cardiovascular events such as myocardial infarction or strokes. The combined effect of these conditions elevates this risk even further. Treatment for these conditions must be carefully balanced. For example, diuretics used to manage fluid overload in CHF must be adjusted to avoid worsening kidney function. Medications for diabetes need to be managed to avoid complications related to renal function, such as adjusting dosages of insulin or other glucose-lowering drugs. Managing these conditions requires careful dietary management. Patients may need to follow a diet that is low in sodium to help with fluid retention, controlled in carbohydrates to manage blood glucose levels, and potentially restricted in potassium and phosphate due to renal failure. Integrated care involving cardiologists, endocrinologists, and nephrologists is crucial. Regular monitoring of blood glucose levels, kidney function, and heart function is essential to adjust treatment plans as needed and to manage conditions effectively. The body naturally strives to maintain homeostasis. Unfortunately, as it becomes more compromised by these chronic conditions, it requires more and more medical intervention. Diabetes accelerates atherosclerosis, leading to narrowed blood vessels and reduced perfusion, which can result in peripheral vascular disease, PVD, especially in the lower extremities. This impaired circulation decreases oxygen and nutrient delivery, impairing wound healing and increasing the risk of infection and gangrene. Diabetes also causes peripheral neuropathy, where elevated glucose levels damage nerves in the extremities, reducing sensation and hindering injury detection, allowing minor wounds to become infected and progress to gangrene. Diabetes impairs immune function, creating an environment conducive to bacterial growth. Infected, non-healing wounds or ulcers, particularly in the lower limbs, can lead to severe infections and gangrene. In patients on hemodialysis, fluid accumulation often causes skin changes such as discoloration, dryness, and scaling, and can lead to cellulitis. As diabetes progresses, it further compromises the immune response, making it difficult to control infections like cellulitis, which can advance to gangrene. When vascular compromise in the femoral artery or the inferior popliteal artery results in the loss of pedal pulses in the distal dorsalis pedis artery, amputation below the knee may be necessary to manage gangrene and infection effectively. As you can see, the body is designed to be in and maintain homeostasis. It will always strive to maintain it until it no longer can and needs help. All of these conditions often go hand in hand. You can definitely have one of these conditions and not another, but more often than not, starting with type 2 diabetes mellitus, it becomes a domino effect.